Good evening, everyone. I welcome you all on this webinar on SI Joint hosted by the Karnataka branch of IAP along with Capri Institute of Manual Therapy on the topic Segmental Assessment and Manual Therapy of the Sacroiliac Joint. Some instructions for our attendees today. There will be regular polls happening. I request all the attendees on the Zoom platform to answer them. Those who are watching us live on the YouTube page, they will see the questions on their screen and they can answer the questions in the live chat. I request everyone to also note down their question and answers and share it in the Q&A section. With this, I would like to invite our co-host of the day, Dr. David Arun Kumar. He is the principal at Hillside College of Physiotherapy and is the vice president of the Karnataka branch of Indian Association of Physiotherapists. I would request David sir to kindly start his video and come online.
Thank you very much, Dr. Tanmay. It's a wonderful opportunity for myself, Dr. David Arun Kumar, the Vice President of IAP, Karnataka branch. I would like to take this opportunity to thank Dr. Deepak Kumar, sir, the Senior Consultant and Chief Instructor of Capri Institute of Manual Therapy, to be associated uh, with Karnataka branch of Indian Association of Physiotherapists to host this webinar on segmental assessment and treatment of sacroiliac joint and dysfunctions with the practical demonstrations. So we are really privileged and honored to have you on this platform on doing this webinar, dear Deepak Kumar sir. Thank you so much, and I would like to thank our President, Dr. Iftikhar Ali sir, whose initiative made this happen. And this is the fifth webinar we are hosting week after week for the professional development of all the physios, clinicians, academicians, and students and interns as well, all across India and even abroad also. And since we are associated with Capri Institute of Manual Therapy, the YouTube live is going across for thousands of people. And right now I see on my screen there are 950 already joined, and it's still the number is going on like that. It's increasing, and thank you very much, sir. It's all because of your charisma that you carry in this physio world in India. Thank you very much, and I would like to take this opportunity to introduce the moderator of this webinar, Dr. Vaishali Srijit, the young and dynamic physiotherapist and academician by profession. She is the vice principal of Dr. M.V. Shetty College of Physiotherapy. She is the board of studies member of Rajiv Gandhi University of Health Sciences, Bangalore, and she is the joint secretary of Karnataka branch of IAP. And she is also the vice president, Sports and Fitness Training Federation of India in Bangalore. And she has been a former principal of City College of Physiotherapy in Bangalore. She was former vice principal in Bethany College in Trivandrum. And the list, it just goes on. We don't want to take a lot of time. And I welcome Dr. Vaishali Srijit on this platform. And she will be the moderator of the entire session. And I welcome all the participants who have taken time on this evening, the Friday evening at 9 o'clock. To attend this webinar. We are really overwhelmed and we are humbled by your presence. We want you to stay till the end and watch the wonderful techniques that our Deepak sir is going to demonstrate practically, and stay till the end to ask all the questions. Over to you, Dr. Vaishali. I welcome you on behalf of IAP Karnataka.
Thank you so much, sir. Thank you so much. So good evening, one and all. So we've gathered today this webinar, the most awaited webinar, I could say, by our beloved Dr. Deepak Kumar, sir. This man needs no introduction according to me, but still I am being put up to say a few words about Dr. Deepak Kumar. It's really a privilege for me and an honor to introduce and to welcome Deepak sir on behalf of the IAP Karnataka branch. And also, I would say one of the most popular figure we all know throughout the nation and also recognized internationally. So a globally well-known personality, a very dynamic person, and in his field, I think he is the best, and he's, so much we have to learn from him. His a wide range of knowledge, the way he shares it with all of us, and it's really very enthusiastic to always have a listen to a session of Dr. Deepak Kumar sir. And as I said, I can't give an introduction about Dr. Deepak Kumar sir, but still I'll try my best. He's the director and he's the senior consultant of manual physical therapist at Capri Institute of Manual Therapy. He has treated more than 100,000 patients and trained more than 13,000 physiotherapists and conducted more than 250 workshops. His book, Manual Therapy of Mulligan's Concept, is a bestseller on various platforms and is translated in various languages like Korean, Chinese, Russian, and it is soon coming up in Arabic language as well. So, sir, we are extremely esteemed to have you, and on this day, at this time, so that it's 9 o'clock when they said the timing, it was like, okay, everybody is free, all have finished of their work, and they're just sitting free live and watching, waiting to hear from you. And to all the our audiences in the webinar today, I'm very sure you people are going to have a fruitful session by Dr. Deepak sir. Once again, I welcome Dr. Deepak sir, and we are very grateful to have you today, sir. Over to you, sir.
Thank you, Dr. Vaishali. Thank you, Dr. David. And thanks to Dr. Iftikhar, President of IEP Karnataka branch, and Dr. David, Principal and Vice President of IEP Karnataka branch and Joint Secretary of IEP Karnataka branch and Vice Principal at M. Shetty College, Dr. Vaishali. Thank you so much for inviting me and giving this opportunity to interact with my fellow physios. Along with me, I also have Dr. Ruchi Gupta, and she's a very experienced physio working with us since last so many years. And she's working as a head of the department in Capri Spine Clinic in East Delhi Clinic. So she's also one of the panelists. So I welcome you, Dr. Ruchi. And Dr. Ruchi will keep answering your questions. If you are asking any question in Q&A section, so Dr. Ruchi will keep answering your questions. And if some questions are still left in the end, so I'll try to answer those. In between, as Dr. Tanmay already told you, there will be poll coming in between. So please try to answer those polls. There is nothing wrong or right. So don't worry, nobody will come to know your name. And I'll try to keep this webinar as interactive as possible. And it should be very fun-filled, and I try to make it easy. And it's going to be all practical, okay? Except the first few minutes, it's going to be all practical. And like my all webinars are full of practicals. And what I'm going to show you here and what I'm going to share you is the what we practice actually. Okay, what we teach in the workshops and what we practice, what my clinicians practice. This is what I'm going to show. It's all going to be all clinical related. Okay, so without spending further time, let me start this. And please don't leave in between, because in the end we'll connect all the dots and you will have the complete picture. Okay, the suspense will get in the end. Okay, so you will get the suspense, you'll get the real picture in the end. So don't leave in between, then you may go out with the half knowledge. Okay, Hindi mein bolte hain na, like neem hakim khatraye jaan. Okay, half knowledge is bad actually. Okay, so let me start the things now. Okay, share the screen. Let me fix this. Okay, so this is the topic: sacroiliac joint, segmental examination and treatment using manual therapy. And before I proceed further, let me check with whom am I communicating with? Are you students or the postgraduate students or the clinician or academician or researcher? So if you could please let me know. So accordingly, I'll take up my presentation. I'll modify my presentation. I'll change it accordingly. Okay, so if you could please answer it as early as possible, whether you are undergraduate or MPT or clinician or academician or researcher, administrator. I'm sorry, this may not be seen in YouTube, only this poll. Okay, all future polls will be seen on YouTube. This poll is probably not seen on YouTube.
I request all the attendees to answer in the poll and not in the chat box.
Okay, so we have 40% undergraduate, 17% MPT, and 42% clinician. Unfortunately, only 6% academician. That's fine. Majority of the time in my workshop, I do attract clinician and undergraduate. This is what the kind of practice we have. That's fine. It's okay. Okay, let's start the presentation now. So this is what we are going to cover. What is the SI joint, sacroiliac joint? Can it cause pain? Why I'm saying? Because the literature says SI joint pain is very rare. Majority of the time people are getting pain from the lumbar spine. That's why. So we need to discuss, can it cause pain? And how do you do segmental examination? This is going to be the practical one, okay? From manual therapy point of view. And how do I diagnose mechanical pain? Here it is important to note, I'm not teaching you the pathology one. I'm not going to teach you the orthopedics one, because it is not possible to cover those things in just 1 hour or 1.5 hours, depending how much time it takes. So today's webinar may go 60 to 90 minutes in between. And then once you diagnose it's a mechanical pain, how do you fix it using the different manual therapy techniques? So I'm going to show you manual therapy techniques for the assessment as well as for the treatment. What I'm not going to cover is the anatomy and the special test or the pathology. So those things I'll not be entertaining. And let me see, what do you think? What is the lifetime prevalence of the low back pain? So people on YouTube can type it in their chat box, but those who are on Zoom, there is the poll. So what do you think? What is the lifetime prevalence of low back pain?
30 seconds for the attendees to answer the poll. I request all the attendees to answer it in the poll and not in the chat. 10 more seconds.
Okay, so 40% people think it is 60% and 34% people think it is 80%, which is the right answer. It is the 80% is the lifetime prevalence of the 80% is the lifetime prevalence. Means 80% people do have back pain sometime in their lifetime, and it is very much second to the common cold and cough. Okay, I'm not talking about corona cough and cold. Okay, it is a different common cold and cough I'm talking about, and it ranked fifth, okay, for the hospital admission. And in America they spend $86 billion per year. In India it might be different, but probably going to be almost somewhere similar, because maybe the value is down but the population is high. Okay, so what are the potential pain generated in the low back pain? From the spine, it could be facet joint, it could be disc, or the ligament, or the bone. And when a physio assess patient, these are the things he always concentrate for the low back pain. These are the things we always, if a patient comes to us with the low back pain, we look for the facet, disc, and the ligaments, and the bone. Rarely we go for the hip joint and the sacroiliac joint. There are few reasons which we'll be discussing why. Because when the patient comes to the clinic, majority of the time they come with the MRI films. And in MRI film, they see all those things, not the sacroiliac joint. They rarely comment on that. Also, the reason that imaging studies are often inconclusive, especially for the sacroiliac joint. If to diagnose sacroiliac joint, you want to send the patient for CT or MRI, they are going to be inconclusive. You can't make out through with the help of radiological imaging. In one of the study, they found 42% people, they were symptomatic, but CT scan was absolutely normal in 42% patient. They were having pain in the sacroiliac joint. Diagnosis was sacroiliitis, but CT scan was normal. Okay, but when you want to see the uh, SI joint, okay, in X-ray, don't advise the patient to go for plain AP view. In that, you will get the overshadow and you may not be able to get it. So I advise you to go for left oblique and right oblique, depending which sacroiliac joint you want to see. But always go for left and right both. So you have a possibility to compare. Okay, you can check which one is more, which one is less, and you can see, look for the sclerosis. You can see the joint diffusion or the fusion of the joint going on. So all those things you can still see in X-ray, though it might be inconclusive. You can also go for MRI or the bone scan. So out of back pain, when the patient comes to the back pain, the research says, the literature says, approximately 20 to 25% people, those who are having back pain, they have SIJ involvement. Means if you are receiving 100% with the back pain, almost 25 patients are having SIJ problem. This is what the literature says. But as in my previous webinar also I said, in my experience, those percentages are much more higher. Maybe because those studies are done in different culture, different place, different lifestyle, and India, it is a little different. Okay, so might be it is because of the geographical changes, all those things. So, but in my experience, as I said, it is much more, and the literature says 25% people. It is much more common in elderly, obviously, because of the degenerative changes. So when the percentage is 25% people, okay, how can you miss them? How can you not assess patient for the sacroiliac joint pain? So before that, I proceed further how to assess. Just as I said, I am not going to cover the anatomy, but just very fast, I'll go through this slide. So you have the very fast overview, because this webinar is not on anatomy, it is on manual therapy. Okay, so this is the largest axial joint in the body. It is a true synovial and diarthrodial joint, has a hyaline cartilage and synovial membrane like any other joint, and subject to same pathology like any other joint. Average surface area is 17.5 centimeter square centimeter, and it is a weight bearing triplanar shock absorber joint. Okay, because when the force comes from the spine, it get diverted to both ilium, okay, from left and right, and it absorbs the shock and then transmit load from the upper body to the lower one. And if until unless person is suffering from ankylosing spondylitis, this does not get fused. In case of ankylosing spondylitis, this is the first joint to get fused. And unlike other joint, it has a complex anatomy. It does not have a very smooth surface. It has irregular surfaces. The shape of the joint surface is boomerang. Sometimes people call it L shape. I believe more in boomerang. It's easy to imagine. Okay, and it is like choti pahadiyan, mountains. Okay, not Himalayan I'm talking about, but the Mussoorie and the northern India's mountains. And but it is surrounded by, first thing, it is because it is irregular, so it gets logged very nicely with the ilium. And second thing, when the not only get logged properly, but also there are ligaments, there are capsules and the muscles which hold the joint. Okay, so it is a very rigid, very stiff joint, doesn't move much. And to move that, you really need to apply good amount of force in order to mobilize it. Okay, good amount of force does not mean that you jump on the patient. Good amount of force, I am talking in relationship to the force you apply on other joint, because on other joint you just push it very gently, but here it's going to be a little more than that. Okay, and this is also very highly innervated, like your fat pad in knee joint. Fat pad is very highly innervated, and majority of the time pain comes from the fat pad. Same way, even the sacroiliac joint is highly innervated, and you get it's when it get upset, it gives very severe pain. So as I said earlier also, SI joint often get missed as back pain. This may not be true in case of physiotherapist, but unfortunately with our other medical fraternity, it often get missed. And this is what I came to know from various orthopedic surgeon and spine surgeon, because they concentrate more on the spine, and probably they have limited treatment for the sacroiliac joint. So that also could be one of the reason that the sacroiliac joint often get missed during the diagnosis. And usually they don't examine it, because they already have the MRI, they already have the reason to believe why the patient is having back pain, like uh, disc or the facet joint or ligamentum flavum hypertrophy or the spinal canal stenosis. So many things are there, and they have a reason to believe for that back pain. So they often miss out. Then SI joint dysfunction often misdiagnosed and not even considered. And as I already told, imaging studies are often inconclusive. And SI joint can also mimic discogenic low back pain or radicular pain, potentially leading to misdiagnosis, because sometimes it can give you the radiating pain also. And soon we will discuss how to differentiate whether it is coming from the sacroiliac joint or from the lumbar spine, while taking history as well as while doing the assessment. And there is a overlapping also referral pain. As I said, it mimicked with the discogenic pain, so there is a overlapping also. Okay, so what could be the potential cause behind sacroiliac joint pain? Patient may give you fall on buttock, like he was playing football or cricket or running and he slipped and he directly landed on his or her ischial tuberosity. So obviously the ilium pushed up, direct impact there. Okay, and then motor vehicle accident. Now you must be wondering, why motor vehicle accident? It's not a bumper car injury I'm talking about, or say the dashboard injury. I'm not talking about dashboard injury. I want you people to imagine this. So imagine the person is going in a car, okay, and he has to apply a brake suddenly, and then his one foot goes on the brake, and then this leg is getting jammed, locked, okay, and then suddenly there is a jerk. So whole body moves with relation to this leg which is on the brake, and the movement comes at the sacroiliac joint. Okay, I'm not talking about fracture, but yes, there will be stress, strain, or torsion. So I'm sure you are able to imagine that. Okay, because that the foot which is on the brake is in locked position and the whole body is moving forward. So whole body moves and the stress comes on the sacroiliac joint on the side, the one which is on the brake, probably on your, depending which country you're driving actually. Okay, in India it will come on the left leg. Sorry, the right leg. The right leg is the brake. Sorry. Okay, so motor vehicle accident, then heavy lifting. This can give the back pain or the sacroiliac joint also. Childbirth. We know in third trimester, the release of relaxin hormone is there. And during baby birth, the hole has to increase in size. So obviously the ligaments has to give way for the normal delivery of the child. And it often gets strain, sprain, and the torsion injuries are there. So in childbirth also, there might be a history of that. Then lifting and twisting. Okay, so those are the traumatic history in patient may give. And while taking history, make sure you rule out the yellow flags as well as the red flags before you take the patient for the manual therapy. Obviously, you ask all the precautionary question. And this remind me one of my young patient actually. That's long back, almost 26 years back. The young boy came for the treatment, and we tried our level best. And there was no history of red flag or yellow flag, no fever, no temperature, no loss of weight, no loss of appetite, nothing. And he was not responding. So we sent him for the MRI, and we found pus formation in the sacrum. So sometime when patient is not responding with your treatment, think of something serious. And best thing to find out red flag and yellow flag is if the movement is not getting provoked or not getting relieved because of movement. If the pain is not getting increase or decrease because of the movement, think of some pathology. This is important. In case of mechanical pain, the pain will increase or decrease with some movement of that affected joint, but I'm sure you have to move it in appropriate direction. Okay, atraumatic. What could be the atraumatic one? Adjacent segmental disorder, lumbar hypomobility. Obviously, if the lumbar spine is not fully mobile, so the stress comes at the sacroiliac joint. Okay, because each lumbar vertebra has to move 510 degree, 510 degree, 510 degree. But if they are fused, then entire stress comes on the sacroiliac joint. And I'm sure you people are aware, you get more degenerative changes at C71, C67 and C71, because after good mobility, you're suddenly getting hypomobility, less mobility. So that makes the hinge. Same way, you get more degenerative changes at L5 because there's a good mobility and then there is a hypomobility suddenly. Same thing is applicable to the sacroiliac joint also. If the lumbar spine is hypomobile or fused because of the surgery, they put the plate, they put the nail, okay, and they fuse the lumbar spine. So it becomes like a block movement. And obviously, when it is like a block movement, the wanted movement, the required movement has to happen somewhere. And then the sacroiliac joint get torsion. So make sure you assess your patient after the surgery in case they are coming after the fixation for spondylolisthesis or after any fusion of the vertebra. You make sure you assess, you think about the sacroiliac joint also. Then scoliosis, because of the scoliosis, there is uneven force on the sacroiliac joint on one side. Then postpartum, that we have already discussed in case of normal delivery. Then in case of inflammatory arthropathies or the infection. In case of infection and inflammatory arthropathy, even the resting pain will be there and movement will make no difference. So take the history properly. Now, these are the percentage as per research, okay? 44% out of traumatic injury, direct traumatic injury, 44% people will have sacroiliitis or sacroiliac joint pain. 21% because of the cumulative injury, day-to-day activities, they are getting the uh, micro traumas on daily basis because of the posture, because of the wrong way of working, because of the occupational things. Something is there, and they are, or too much of walking, too much of stair climbing, something is there, and they are getting repeated micro trauma, and that is why they are getting the pain. Then 19% post lumbar surgery and 16% idiopathic. This is a beautiful terminology medical fraternity has designed or developed. If they are not able to find out what is the reason behind it, they call it idiopathic. But I'm sure sooner or later, once the science develops, we'll be able to find out the cause behind that also. And now my next poll is coming up. And in this poll, what I'm going to ask is, what is the prevalence of SIJ pathology in patient with low back pain? Out of low back pain, what is the prevalence? Okay. And I'm sure you remember because I already told you in the earlier phase. Let's see how much of you were attentive. How many were attentive? Let's see whether you remember or not. How many?
Another 15 seconds for the attendees to answer. I request all the attendees to answer the poll.
Okay, that's very good. 48% people saying 20 to 25%, which is the right answer. Excellent. Okay. And but there's a mixed approach. Please be more attentive, pay more attention to this webinar. Believe me, this is you will it will help your patients a lot when you treat your patients. Okay. So let's proceed further. So prevalence of SI joint pain, all low back pain. Out of that, 22%, or as I told you, in my experience, it is much more than that. So let me ask the second question now. Can lumbar spine surgery lead to sacroiliac joint pain? Let me know. Yes, no, or not sure. Let's see again whether you are with me or doing TikTok. Wow, okay. 91% says true. Okay, good. Means you all are attending. You are with me. That's very nice. Very nice. And you know the percentage? The 43% people. 43, that's a big percentage. Okay. The 43% people after lumbar fusion or after lumbar surgery, after lumbar fixation, they do get sacroiliitis, sacroiliac joint pain. And when they come to your physiotherapy clinic and you are wondering, it's already fixed, what I'm going to do? Probably it is not that operated site. Probably it is the sacroiliac joint you need to address. Okay. I hope this is a good information for those who are practicing. Okay. This is another study. This says those who got operated because of any XYZ reason in his spine, okay, whether microdiscectomy or lumbar spine fixation or laminectomy or something, in them, and at the later stage, 75% people showed SI joint degeneration as compared to those who did not got operated. Those who did not got operated, they were having 38.2% people got degenerative changes, but those who got operated, it is 75%. That means after surgery, majority of the time, if the pain is coming, it is because of the sacroiliac joint pain. Because after surgery, patient thinks many times the disc is out now, there is no problem, it's already fused, and then they don't work for the strengthening exercise, they don't work for the mobility exercises of the adjacent joints, and then these joints also starts getting affected. Proper rehabilitation is important means in those cases. Proper rehabilitation of the adjacent joints, the level above and the level below. Okay, so let's see next. How do you check whether it is sacroiliitis or not? In my last webinar, I said, I gave one very strong statement and many people agreed or disagreed. This time I'm there with the specific name, 14th finger test. Okay, so that is called 14 finger test. Tell me, in 14 finger test, patient pinpoint pain at L5 in case of sacroiliitis. Okay, if the patient is suffering from sacroiliitis, where will he pinpoint pain? At L5 or the anterior superior iliac spine or posterior superior iliac spine or the sacral spine? This test is called 14 finger test. Dr. 14 developed it. So simple and easy.
Another 5 seconds.
Okay, the 54% people are right. It is the PSIS. So when you get a patient, he will, and you ask, where is the pain? Put your one finger. He will exactly put it on the PSIS of the affected side or within the radius of 1 to 2 centimeter. within 1 to 2 centimeter of the PSIS he will put. And you ask him to remove the finger and ask him to put it again, and again he will put the finger in the same place. Okay, so twice. And this is what you do. This is one of the confirmatory tests that this is a sacroiliac test. This is called 14 finger test. In addition to this, you obviously you have to do the examination. You take the history of the patient, and then you do the physical examination. Very soon we are going towards the practical part of it. Okay, so you do the presentation history, presentation of the pain, take the history from the patient, do the physical examination for the lumbar spine, sacroiliac joint, as well as the hip joint. Here in this webinar, I'll not be discussing lumbar and hip joint. We'll be discussing only sacroiliac joint. And then 14 finger test also that we have already checked. And then you also need to do the positive provocative test. So I'll be doing those provocative tests from the manual therapy point of view. Okay, because there are so many tests and there are so many names. Being a clinician, I don't try to remember those names. Okay, but I try to remember the physics behind it, the vectors and the force, and what I'm stressing, what I'm compressing. Provocative test means you have to provoke the pain, not a pain. The pain is the same pain what patient was complaining of. Okay, the relevant pain I'm talking about. So what the chief complaint patient will do, since we have already discussed all those, so probably I'll go a little fast. So patient will complain pain below L5, not above L5. This is very clear. Okay, so within 2 centimeter area of the PSIS. Then the pain may go down in the pelvic or the buttock area. Then sometime, sacroiliac joint can also travel in the front area, groin area. Okay, and we all know when we talk about pain, we know that pain can travel front to back and back to front, but not from left to right or right to left. We call it law of pain. In Capri, we have developed this language. Okay, so let me repeat it once again. Pain can travel front to back and back to front, but not from left to right or right to left. That means if the left side is affected, patient will get pain on the left side, essentially. Okay, so patient may also have a disturbed sleep pattern because turning in the bed is painful. Because when you turn, obviously the sacroiliac joint get strained. Okay, there's more torsion on over the sacroiliac joint, and then sitting, disturbed sitting pattern also. Patient don't want to do the loading on the affected joint. He won't sit straight. He will try to offload the affected side. So when patient comes through the walking pattern also, you can make out he won't be putting much load on the affected side. Then during standing also, he won't be putting much load on the affected side, as well as while the sitting also. And you can check the unilateral leg instability also in the, and pain can go to the lower extremity. These are the few important points when you diagnose your sacroiliitis pain, sacroiliac joint pain. Pain will never be in the midline. If it is in the midline, it's coming from elsewhere. It's going to be either left or right, or if maybe bilateral is there, then it's going to be left and right, but not in the midline. And it's always going to be below L5. Okay, we have already discussed. It's always going to be below L5, within 2 centimeter area of the PSIS. Occasionally, it may go to groin area or the posterior lateral thigh or the calf area. Most commonly, patient point to the PSIS. We have already discussed the 14 finger test. Okay, and these are the aggravating as well as the relieving factor. Rolling on affected side in lying, supine lying. That's why it is a disturbed sleep. Okay, sit to stand gives pain because there is a loading, extra loading there. Then prolonged walking, when patient walk for a longer time, and then getting in and out of the bed. Again, you are putting strain all the time. It is a very nasty joint. Even in sitting, you do the loading there. Then unilateral weight bearing will also give pain, like putting the pants or the socks or climbing stairs, because during climbing stairs, when you put the affected leg on the stair, it will give pain. And standing or walking, a stance phase, the affected leg on the stance phase will cause pain. Then prolonged standing will also give pain. What will be the relieving factor? Weight bearing on unaffected side, lying on the unaffected side, because then there's no compression over the sacroiliac joint. Then compression with the belt manually to relieve hypermobility. In case of it is a unstable joint, you put the lumbar belt or you put the pant belt, wide one, and then it stabilizes it better. Patient feels better with that. So you do the examination. First of all, you do the posture. And you know, many times people think they know the posture examination. I'm glad they think. I'll show you one or two things. So let's talk about that when the slide comes. We'll cross the bridge when it comes. And next is the palpation. Check the tenderness over the PSIS and the sacral sulcus, tenderness over the dorsal ligament insertion, tenderness over the pubic symphysis. In India, we don't do those tests because socially it is not acceptable. Then, like you, in the peripheral joint, in the knee joint, in the shoulder joint, you check the active range of motion as well as the passive range of motion. Then why not in case of spine? Why not in case of sacroiliac joint? I'm going to show you how to do the active range of motion as well as the passive range of motion check during the practical demonstration. And then we will be doing the provocation test. We'll be doing multiple provocation tests. And as per literature, out of 5, 3 should be positive. Out of 5. Okay. And one law we have already told you. Pain can travel front to back and back to front, but not from left to right or right to left. Okay. But there is another law now. We must know the another law. Another law is, just 1 second, if you could please hold on. आप लोग चले जाओ यहाँ से, दूसरी जगह बैठ जाओ. Okay, sorry for disturbance. Another name is any neuromusculoskeletal pain. Any neuromusculoskeletal pain, if can be provoked, will get provoked either by maximum compression or by maximum stress. Any neuromusculoskeletal pain, if can be, I'm not talking about visceral pain, okay? I'm talking about neuromusculoskeletal pain. So any neuromusculoskeletal pain, if can be provoked, will get provoked either by maximum compression or by maximum stress. And you will notice all orthopedic tests are designed in such a way that you are either compressing or you are stretching. Okay, same way for the sacroiliac joint also. So I don't try to remember them by name, but as per the physics involved in that, how I'm stressing, vectors, angle, force, all those things. Okay, so maybe it's your choice, but obviously academician and students must remember it by name also. You have to pass the exam. Okay, remember that. And then you have to do the gait assessment, single leg stance, functional testing, stair, sit to stand, and active SLR. These things are not possible to show in webinar in limited time, so I'll not be showing what you see in yellow color, but everything related to the manual therapy. Then gold test, you know, the SI joint injection. If after doing all those tests also, you are not able to make out whether it is sacroiliac joint or not, then you inject lidocaine. Okay, lidocaine injection, only 1.5 ml in the sacroiliac joint. And after 20 to 30 minutes, if patient is almost 80% better, that means it was a sacroiliac joint. This is for those medical people who are there in the webinar. So maybe you can inject. Physios cannot inject. We don't do invasive therapy. We do non-invasive one. Okay, so you can inject lidocaine. And that also probably you should repeat after a few days and reconfirm before you plan to go for surgery, before you plan to go for the fusion or fixation, to make sure that it was the sacroiliac joint. Okay, so this is the gold standard actually in medical practice to diagnose, to confirm the diagnosis of sacroiliac joint involvement. So let's jump to the postural examination. For postural examination, the area should be well exposed. We are proceeding towards practical slowly. Okay, so area should be well exposed. In natural daylight you're going to see, and the distance between feet should be even and equal all the times, natural standing, and make sure you ask patient to keep his eyes closed, because if he's keeping his eyes open and he know you are examining him, he will try to adapt the best posture he can. Okay, so what I do, I ask patient to stand natural and then close his eyes, and then again do we call it kadam tal. You do left right on the one place, standing on one place and moving your arms, moving your leg, and then all of a sudden you stop, and then you ask him to acquire a posture what he think is the neutral or the natural for him, and he's keeping his eyes closed, and then you get the real posture, because this is what his cerebellum think is the neutral position. Okay, not the person who think it is the neutral position. So keep it with the eyes closed. But yes, if someone is having vertigo problem, or if someone is having old age, then maybe you can give some support, or you allow patient to open his eyes in between. Okay, then you check the natural position and the neutral position. So how do you check whether the pelvic is rotated backward or forward? From the back view, you cannot make it. Okay, and many people see it only from the behind, or from the front, or from the side. So this is what you should also examine. Have a bird eye view. Okay, so look from the top, and when you watch from the top, you will see if the pelvic is rotated backward or forward. If in this video, in this photograph, I'm sure you can make out, you are able to see more of calf hair and less of calf hair. Okay, that shows this portion has rotated backward. Okay, so you have to see the axial rotation also, not just the anterior tilt, posterior tilt, up slip or down slip. You also need to see the axial rotation. And when you watch from behind, okay, so this line and the line in the front should match with each other. If they're not matching, suppose this line is here and the person has rotated, I'm sure you concept, please watch my hand. If the person is rotated like this, okay, let me go back. Now, if the person is rotated like this, so this line and the front line will not match because the person has rotated. If I probably I'll try to do it in the practical demonstration also, and probably it will be more clear. So when whatever you see in the back, you must confirm from the front. If you're not able to confirm from the front, probably you can discard it. And then let's get closer, mark the PSIS, and I'm sure you are able to make out the height difference. Okay, and it's quite looking quite different, quite high. You know why? Because the cloth of the patient is oblique. He's not wearing his shorts properly, and that is why the difference is looking too much. So make sure the height of the trouser or the belt or the shorts are even with the floor, so that you don't get confused. So it is a little high, no doubt, but not as high as was seen in this one. Okay, so you see that, and then from the front again you confirm that with the ASIS. Again, I can see this is high a little bit as compared to this, so it is confirmed. If it was not, then probably I would have discarded it. Then watch it from the side. Okay, straight line from the pubic symphysis and ASIS, and then you can see the anterior or the posterior tilt, and then the PSIS and the ASIS, though it makes some very small angle between PSIS and ASIS. Okay, so those are things you should see in the posture. And then we'll start your palpation and the active range of motion, passive range of motion. After just 3 more slides, we are starting the practicals. So how mobile is the sacroiliac joint? Very less mobile, very, very stiff. It moves only just 4 degrees in any plane, just 4 degrees. Okay, so you have nutation, counter nutation. In male, it is 1 to 2 degrees, and in female, it is 2 to 4 degrees. Okay, and then you have a sacral translation. AP motion is just 1.6 mm, 1.6 mm. It is, yes, it is very, very difficult to appreciate. Until unless you gain those palpation skills, you practice a lot, you will find it difficult. And there are a bunch of people who says that they cannot appreciate, or there's no movement, the people are making fool. Maybe at the same time, there are people who says they are able to appreciate all the range of motion very comfortably. Now, I do not know whom shall I believe. I believe myself. I'm able to feel it, okay, with my 28 years of experience. So I'm going to go as per my experience. So you will see both people. People says you can't, and people say yes, you can. You decide to whom you should trust. Then there's an axial rotation 1.5 degree and lateral bending 0.8 degree, very, very minimum. It is a good example. It's like an earthquake. Lot of energy required, but how much the earth move during the earthquake? Just a little bit, and so much of energy is released because such a strong ligaments around the sacroiliac joint and the muscles holding the sacroiliac joint. It doesn't move so easily. It's very subtle, very little bit. Okay, now I'm going to show you videos where I have exaggerated those movements so that my students can understand what movement I'm talking about. They are able to visualize, they are able to imagine. I have exaggerated those movements by more than 100 times. Okay, so see those videos, and it's just not nutation or counter nutation. There are multiple axes because sacrum moves not in one axis. It moves in minimum 3 axes simultaneously. Okay, so it's not pure nutation, counter nutation, or up slip or down slip. It moves in 3 axes simultaneously. So I'm going to show you all the axes so that you can understand the test, assessment, as well as the manual therapy techniques. So these are the axes. We have a coronal axis, then we have a vertical axis. So obviously in the coronal axis, you will get the nutation, counter nutation. In the vertical axis, you'll see the sacrum rotating around its axis. And then we have the right oblique as well as the left oblique. Okay, so now I'm starting this video, and again I'm saying I have exaggerated all the movements by many times. So let's see how it goes. So let me play this. And after these 2 videos, we are going to start the practicals. So these are the axes, and look for the nutation and the counter nutation. I repeat, it's exaggerated too many times so that you people can appreciate the movement. And this is the axial view. And I'm so happy to tell you these all animated videos has been developed in our own digital lab in Capri Institute of Manual Therapy. We have developed it. We have the copyright with this. And thanks to Tanmay for developing all those animations. Look at this left oblique and right oblique. Okay, so in left and right oblique, this is how it is going back and forward. Okay, and because this is the axis. Now the axis has been changed. Okay, so maybe I shall show you just once more this video so you can understand it better. This video is only for 55 seconds, okay? So it doesn't take much time. Tanmay is indicating me that I'm going too slow. We need to go for practicals. Yes, we are going for practicals after these 2 videos. Each video is for 1 minute, that's it. So within 2 minutes, we are jumping into practicals. Nutation, counter nutation, then around the vertical axis, and then you check the left oblique and right oblique. Okay, so you see the movement. This is with the left oblique. Okay. and it will become very easy for you to understand the glide. You know, very, very easy to understand glide. Now that's the right oblique axis. You name the axis as per the top, okay, not as per the bottom. I feel so proud that these videos has been developed in our institute, in our lab. Okay, so how the ilium moves. Yeah, this is the last slide and last video, and then we are starting the practicals. Okay, so forward, backward. It can go, yes. And then it can go forward, backward, same way, from the outer side and then from the inner side. So you understand which glide you want to do. And then it can go up slip and down slip. Okay, again, this has been exaggerated many times. Okay, this is out flare and in flare, out flare and in flare, same out flare and in flare. And if you notice during out flare and flare, you'll see one time it is getting jammed and another time it is getting jammed. So when you do those tests, you can make out. Okay, now that's the anterior tilt and the posterior tilt. Okay, anterior rotation and posterior rotation, same thing, but from the different angle. Fine, so let me start the practical part of it. I must stop sharing my screen. It's all going to be practical. Stay tuned, don't go away. So all these things what we have discussed, now I'm going to show how to check the posture, then the active range, passive range, palpation, and the provocating test, and the and the manual therapy. Okay, so let me close the screen from here.
It was a wonderful. Meanwhile, as Deepak sir is preparing for the practical session, let me tell you, sir, it was a wonderful presentation till now. You brought in from the assessment, diagnosis, radiology part, and the visual assessment part, and then you're coming with you showed us a video. That video was amazing for the sacrum moving around the different axes. It was wonderful. And we are excited about watching the live demonstration now, sir.
Okay, so one minute. Okay, so first I'm going to show you the same thing what I'm going to do on my model. Same thing I'll show you on the plastic model. So, okay, yeah, fine. Yeah. Okay, so first I will show you on the plastic model so you know where my hands are placed, and then I will do it on the model also. So one, to check the movement between sacroiliac joint, I'm going to place one hand on the PSIS and another hand on the S2. And then I will ask my model to move. And when the person moves, actually, yeah. And when the person moves, the sacrum should move, followed by PSIS. Okay. But if we ask person to bend his knee, that's going up like that. So what do you think? What should move first? It is the PSIS should move downward first and followed by S2. That's the normal one. But if the S2 moving first or moving along with the PSIS, then you can make out that this is rigid. This is stiff. Okay. So the video is coming in frames. So very first thing you're going to find is the PSIS, the dimples there. Okay. And then you sit down. Maybe if the patient is old, you can give some support to the patient and ask him to slightly bend the knee, and then put your hand on the PSIS. Please wait. Put your hand on the PSIS, one thumb on the PSIS and one thumb on the S2. And then ask person to bend gently forward. Keep going, keep going, keep going, keep going. And then it is the PSIS moves, okay? And then come back, come back. Now, because he's a young man, so I'll ask him not to take the support, okay? So now, could you please do it again? So now, keep going, keep going, keep going, keep going, keep going. I can feel that S2 wants to move now. It is moving. Keep going. And now the PSI is going. Okay, that means it is a normal mobile, come back, normal mobile sacroiliac joint. Now, what I'll ask him to take this knee towards the chest. Now, he should take the support because he's going to come on one knee joint. Otherwise, he will fall. So now the PSI should move downward first, followed by S2. So could you please bend the knee? Yeah, keep going, keep going, keep going. And now the PSI is going down and then S2, okay? That's fine. Take the support and then come back. Come back. No need to bend so much when the real patient comes. He's a fit model. That's why he's able to bend that much. Okay, so this is how you check the active range of motion. Very soon, I'm going to show you the passive range of motion. And in between, I must show you the axial view of the sacroiliac joint. So you go there, okay? In this case, it is looking quite even, okay? Both bumps are looking okay. It is not rotated. And then you should also go anteriorly and look for the ASIS. Palpate the ASIS there. Come to me. Hold it there. And palpate the ASIS and check for the orientation. And the same way, you ask patient to keep the there and keep the head. And then you watch it from the side, okay? Check the ASIS and the PSIS level, and yeah, and check for the level if it is anterior tilt or the posterior tilt. So this is how you check the active range of motion. Now I'm going to show you the passive range of motion. First on the model. So for the passive range of motion, what I'm going to do is I'll be standing behind the patient, and then this is what my purpose is to move, okay? This is how I'll be, this is not my hand grip, but this is what the movement I want to take place. Fine. Lie down now, please. Back to face towards me. Okay. So I'm going to put my elbow on the shear tuberosity so I can lock it, and the hand on the ASIS, so that I can rotate with one hand only. Why? Because second hand I want to use it for the palpation. So I'm going to put one hand at the PSIS and another one at the sulcus, and I feel the movement difference between the PSIS and the sacrum. So now I'm going to do this movement. So that's a posterior rotation I'm trying to do. And I can feel the joint play between the PSIS and the sacrum. Okay. This is called short lever. You can do in the long lever also. If you're not able to palpate or you find this grip as difficult one, then you can hold one leg, okay? And then you bend it into flexion and you can again feel the same way. You want to have the anterior tilt, take the leg into extension, okay? Or how do you do in a short lever? Earlier I did this. Now I'm trying to do this grip. Keep the knee slightly flexed, okay? So now I'm holding the shium tuberosity and the iliac crest and then trying to take it forward. And then provoke the pain or check the pain as well as appreciate the joint range of motion. See the result. So you check the active range of motion. First you check the posture. You take the history that we have already discussed. Next is your active range of motion. Then we did the passive range of motion. And now we have to do the provocative test. Okay? So patient lies supine comfortably. and you expose the ASIS of the patient. Okay, one hand goes on this, like I'm going to cross my hand, because it's easy to apply correct angle, correct vector, and then give the pressure there. I'm doing very large movement so you people can appreciate, but on a real patient, I will not be doing that much. On real patient, it is going to be this much. I don't know now if you people are able to appreciate or not. So I'm going to increase the amplitude so you appreciate. But on a real patient, I repeat, I will not push that way. So that's the movement. Okay. And check for the fine. Then you can also do the fibber of the ASIS and then let it go gently. And then, is that fine? Wait, I need to check. Sir, is the voice audible, David sir?
Yes, it is.
It is audible? Okay.
Yes, it is audible.
Okay, great. So you always do it for the both sides. So you can always compare and contrast. You can always check it. Always do it for both sides. Okay. So stabilize and then push it there. Next one is the shear test. For that, I'm going to stand on the opposite side of the patient. So I'm going to put my hand there at the PSIS and then grab it and then push the femur back along the long axis of the femur. In this, one mistake the clinician can do, he may push from the patella and may produce knee joint pain. So I'm not going to do that. What I'm going to do, I'm going to hold it there and then put it there and then push it. Okay, and check if I'm able to provoke the pain or not. Fine. And then Gensling test. For that, I take the patient on edge of the couch. Out of these tests, minimum 3 should be positive. Okay, so hold it there. He hold it there, and then I push it down. I'm pushing it down, and then it should provoke pain there. So these are the provocative tests you should do and reconfirm. Okay. Now, once it is confirmed, you have to mobilize the joint. You have to go for the manual therapy. Okay. So how do you mobilize? Now, yeah.
Maybe you can also tell the 14 finger test to our people, just where the patient will point out.
Okay. For the 14 finger test, if you ask the patient, where is the pain? Patient will immediately put it on the PSIS. One finger, PSIS. 14 finger test. And you ask him again, put it, and again he'll put it in the same place. Not here. We'll again put it there only. 14 finger test. That's another important test. Thank you for reminding. Okay. So now, how do you mobilize it? Front line. Lie down on your tummy. Page cable. So you also need to palpate the sacrum. Okay. Relax. Maybe you can remove the pillow. Yeah. So you again palpate the PSIS, palpate the sulcus there, and find which one is deep in case it is deep. Okay. Or check for the nutation or counter nutation. Okay. Check for the nutation or counter nutation. But what I prefer to do, I give the glide because earlier also I said, remember this thing very carefully, okay? And don't tell this to your teacher, you will be failed. Actually, in physiotherapy, we don't treat patient. In the name of treatment, we repeat our assessment. For example, how do you check incoordination? Touch my finger and your nose, and patient is not able to touch it. then what is your treatment? Touch my finger and your nose. If the patient says, I'm not able to bend my elbow, what is the treatment? Come on, bend your elbow. Patient says, I'm not able to stand straight. What is the treatment? Stand straight, isn't it? Same way. So in physiotherapy, your assessment is your treatment. In manual therapy, your treatment is your assessment. So what practice we follow after all those things and after confirming whether it is sacroiliac joint or not, and once we know, yes, it is the sacroiliac joint, we do the glide. And my first choice of glide is posterior medial glide. And there is a reason behind it. Because you will notice and you will agree that majority of the population are having pronated foot. And because they have the pronated foot, the talus goes down in it. And because the tibia goes in, and then the femur goes in, and then the ilium bone also goes in. Okay, and you have to do the posterior medial glide. And the moment you do the posterior medial glide, the pain goes away. So majority of the time, it is the posterior medial glide that will work. And then there is an up sleep, down sleep, nutation, counter nutation, all those things. So first technique, first thing first, the most important one. Okay. Posterior medial glide. So if this is the affected joint, now we are at the treatment part, okay? So if this is the affected joint, I'll stabilize the sacrum there. If this side is the affected one, I stabilize the sacrum with my one hand, and another hand goes on the ASIS, lie down, and then go for the oscillation. Again, I am exaggerating my glide so you people can appreciate what I'm doing. Otherwise, in real life, I'll do only this much. I'm sure now you people are not able to appreciate what I'm doing. But in real life, I'll do like this. But for the demonstration purpose, I'm doing large movements so you people can understand. Look at the angle, vector. Okay, so this is the posterior medial glide. If you need to do anterior lateral glide, put the hand there and then push it anterior laterally. Or maybe you can put a towel or the foam pad on the opposite side and then push it anterior lateral. Now, if it is the extension giving pain to the patient, maybe you can add movement along with the mobilization. So what I'm going to do is I'm going to stabilize this and sustain the glide, and then ask patient to raise his body up using his arm muscles, not the back muscles. Because if we contract his back muscle, there will be compressive forces on the sacroiliac joint, and my glide will be lost. So I'm going to stabilize it there and then give the same glide, and then ask him to come up, please, using his arm muscles, not the back muscles, and then go back. Now, how do I check whether it is right glide or not? If it is a right glide, the pain will go away. So you must ask patient how much pain relief is there. If it's saying 5, 10, 20%, probably it is a placebo. But if your glide is correct, he should say about 20%. 30%, 40%, 50%, then you readjust your glide accordingly. Okay, so my preferred glide is posterior medial for extension. Same way you can do for the flexion also. For flexion, come in all four positions, 40% position. So patient comes in the quadruped position, and for the quadruped position, this is probably a little higher table for me. I should be doing on a lower table so that my forearm angle is correct. So what I'm going to do is, again, my hand is I'm going to stabilize the sacrum and then pull it, and then again ask him to push his body using his arm muscles, not the back muscles, not the hip muscles. Okay, so you have to come down and sit here. Okay, and then come back. And हाथ नहीं हटाने हैं. You have to push it with your hands. हाथ से धक्का देके आना है. हाथ नहीं हटेंगे. So wait. Now stabilize it, and then I maintain my glide, and then ask him to come there, and then go back. So I'm sustaining my glide. And this technique works so beautifully. Majority of your patient will respond, and I told you the reason why posterior medial works majority of the time. If you want to do anterior lateral, push it there, anterior lateral, and then go down. Go back. Now, if the audience is looking for self-treatment for the patient, that we are going to launch it soon on our YouTube channel, Deepak Kumar Capri. So I'm going to save time here for self-treatment. There'll be another webinar or YouTube video, and you can watch it there. Self-treatment, I will post it for the patients. Right now, this is all for the physios, how to treat patients. Now, in case it is a upslip, how do you treat that? Please come and sit here. Yes. Okay, so suppose if this is up and you want to take it down, okay, if this PSI was up and you want to take it down, the unaffected side rests on the table. Affected side goes off the table, but make sure the foot is resting on the floor. Just put the toes there, okay, so that his quadratus lumborum and the other muscles are not working to hold it. Otherwise, I'll not be able to push it against those strong muscles. So now I put my hand there and then I push it down, and then I can do the oscillation. Again, I'm doing exaggerated movement so you people can appreciate, or sustain the glide and then ask person to move towards me, and then go back to neutral. And then bend towards me, touch your shoulder with my chest, yes, and then go back. Purposely, I'm not asking to go on opposite side because quadratus lumborum will pull and my glide will be lost. Suppose if this is already down, okay, it is already down. So what I'll do, I'll make him sit other way around. Could you please face this side? Same way. Okay. So this was down, now this is up, this side is up now, and now this is hanging on the side and is touching the feet, and then you hold the sacroiliac joint and then we push it down. Okay, so this is how you treat upslip and downslip. Come here. So how to remember these techniques? The first technique, because he was acquiring a position like a lion, so we call it lion's technique. Rather, it is the Brian Mulligan who give the name lion's technique. Brian Mulligan's call it lion's technique. And the second one where he was coming up, I call it anaconda technique. Okay, that he's coming up like a anaconda. Okay, and then this one where half buttock was off the table, I call it aloo bukhara technique, the plum technique. Okay, so it is easy to remember. Lion's technique, anaconda technique, aloo bukhara technique. Next one is rotational one. Okay, so please lie down. Books. Okay, can I? Books? Yes, please give me a moment. Can you please put it for me? Thank you. Okay, so I'll show you how to manage rotation. Okay, because we also did a research in which it was difficult to maintain the glide in weight bearing. So now we are trying to treat every joint in non-weight bearing, because in weight bearing the joint get locked, joint get fixed, and you can't move it. Let it be knee joint, hip joint, sacroiliac joint, anyway cannot move. Okay, so we are going to do even the rotational technique in non-weight bearing. So suppose if this one is anterior, okay, this has come up, so I have to push it down. So what I'm going to do, I'm going to put one book, okay, nicely wrapped in a towel, so that it should not hurt the patient. But in clinical practice, you should have hard form or the blocks. Okay, so the book comes under one side below the ischial tuberosity, not under the ischial tuberosity, but under the ischial tuberosity. Okay, and then the second book again wrapped nicely. Again, so that it should not hurt my patient. Now this book comes on the other side up to the mid of the sacrum. Okay, so now, and the patient lies straight. So now this side of the ASIS is coming up because of the book, and this side of the ASI is going back, because up to the ischial tuberosity there is another book. So what I'm going to do, I'm going to put one hand there and one hand on the ASI, and then I can give the glide. Purposely, I'm not giving glide. I don't want to produce any strain or the torsion at this model's sacroiliac joint. So purposely, I'm not doing. But what you are going to do is this one. Very powerful technique. Very, very powerful technique for correcting the rotation. And suppose if this is out, so I'm going to put this book down and this book up to the sacroiliac joint. And now I'm going to stabilize there, then up slip, down slip, posterior medial glide, posterior innominate, anterior innominate. Please come up. Lie down on your tummy. Wait, books le lo. Books le lo. Now, what about if the sacrum, you notice the sacrum was moving like that, or also moving like that, then also moving like that. Okay, can I have one mobile? Any mobile? Yeah, sure. So imagine this is the sacrum, okay? So if the sacrum is moving like that, sacrum was moving like that, and then it was also moving like that, and then it was also moving like that, or like this. So if it is already rotated like that, where should you push? You should be pushing here, right? Makes sense. This is the physics, simple physics, biomechanics I'm talking about. And if it is already rotated, where you should push? On this side. And if it is rotated like that, so you'll find the gap, dent here, in sulcus here, and this side will be raised, and you should be pushing on this side. And if it is rotated like this, you should be pushing on this side. If it is rotated like that, maybe there you should be pushing, and if it is there, you should be pushing here, or if it is rotated like that, you should push there, or like this. So you have so many points. 1, 2, 3, 4, 5, 6, 7, 8 points you have. And then how do you decide which one is going to work? The one that takes away pain of the patient, because the movement is so small, you can never be confident. Okay, so you have to do it and check it. So I'll put my thumb there, my hypothenor there, and then push it there, or ask patient to do the offending movement, or stand on that side and then put my hypothenor this side. I'm standing on this side, imagine, and then I'm pushing it there. Or I'm going to push the S1, S2 level, or the S3 level, okay? Or with the thumb, I'm going to push the corner there up, okay? Or the corner, the one that takes away pain of the patient, or the corner down there, or the there. So 1, 2, 3, 4, 5, 6, 7, 8. And these are the 8 points you have to do and check out which one is working. And then fix the pain, fix the faulty position, okay, of the sacrum or the ilium. Now, maybe the question comes, which one will you do? And I told you, the one that takes away pain of the patient. Your treatment is your assessment. So in short, I'll summarize. Check out whether it is a sacroiliac joint pain or not. Okay, the history is different. Patient will give a trauma history, or the motor vehicle accident, brake. He was applying brake and then he got a jerk, or he landed on his feet or on the buttocks. Okay, or the history of surgery, turning, sitting, walking, standing, everything is pain. And then 14th figure test, and then all the provoking tests we discussed. Then the posture analysis, then the active range of motion, passive range of motion, stress test. And then you make out it is sacroiliac joint, and then you mobilize it and check out which technique is working. Though in your assessment, you will come to know. Over the time, when you have experience, when you do a lot of palpation, you will come to know which technique will work. But still, I have given you a shortcut. You do the posterior medial glide, and that is the one which will work majority of the time. Go for the lions, go for the anaconda, go for Alu Bukhara technique, or there are 8 points in the sacrum, you can move them, okay? Or put the book up and down, and correct the rotation, Okay, so this is how you're going to treat, and I'm sure it's going to be very, very rewarding, because it's so difficult to fix the sacroiliac joint when you do not know this biomechanics, if you do not know the manual therapy. Yes, in addition to that, you have to do the strengthening exercise also, which is not a part of this webinar. I'm not discussing that, but yes, in order to hold that neutral position, you have to do the strengthening of the muscles also, release of the muscles. Dr. David is expert in doing the dry needling. You should learn it from him, how to release muscles with the help of dry needling, with the myofascial release. Okay, release those things. Do the strengthening of the weak muscle, release of the tight muscles, give the ergonomic management, posture correction. Okay, all those things. And I'm sure your patient will be blessing you like anything. Over to you, Dr. David. Thank you very much. I hope you people enjoyed this practical.
Thank you so much, Deepak sir. It was a wonderful presentation. We are really overwhelmed to see more than 90 people still on the webinar, tightly sitting at their place and watching you for the last 1.5 hours, and more than 1,000 people on YouTube too. So I want our moderator, Dr. Vaishali Srijit, to take over from here.
Thank you, sir. Thank you. So I think we have a lot of amounts of questions popping up in our.
Can I get the sound?
So I will be starting with a few, and meanwhile, even David sir will be also doing this. So the first one I would like to start with one question which we have picked, which we felt it is a little bit appropriate and apt to be answered.
And before Dr. Vaishali, you ask the question, let me tell all the participants to stay till end, because the question answer also important, and in the question answer also you will learn a lot. Okay, yeah. And then in the end there will be feedback poll. So we will come to know where we went good, where we went bad, and what improvement can we make. So there will be feedback poll in the end, and I request everyone to please give the feedback. And this is what the kick we get. This is what the fee we get in the terms of feedback poll. So please stay till end, maybe another 5-10 minutes, not more than that. Please,
Sure.
Dr. Vaishali.
Yes, sir. Sure, sir. So I hope all the participants, they have clearly heard what sir just conveyed. Please stay till the end, because even the question and answers also have a lot of things to be said about and discussed about. So the first one I would, which we picked up was, do you mean the manual therapy shall not be given in pregnancy? That would be the question, so the first one.
Okay, yes, because...
sorry to interrupt you, Deepak sir. Dr. Tanmay, can you pin Deepak sir's video, please?
Okay. Is that okay?
Not at sir.
So you may please carry on.
Okay. Meanwhile, Tanmay fix it technically. Yes, Dr. Vaishali, the very valid question. In case of pregnancy, I'll ask my physio to first get some kind of experience before they handle. It is not a red flag, but yes, definitely it is a yellow flag. And I'll prefer not to do those glides in terms of when the, especially the third trimester or the lactating month, because that is the time relaxing hormone level is very high. So, but once they gain experience, they can very carefully handle those things. And it's not a red flag, it's a yellow flag. They should try these things.
Yes, thank you, sir. I hope the audience have heard this and must have cleared to some extent at least. Over to you, sir.
Yeah, sir, I have one more question, which is a very appropriate question now. As you mentioned in your slides regarding the movements of SI joint and the nature of the range of motion that he has, that is 1.6 centimeters, 1.6 millimeters and all. Is it really possible to appreciate those tiny movements of SI joint?
Yes, sir, this is really very true. And it is very, very controversial also. And there are people who claim they can feel it. And there are people who claim that it's next to impossible. And because I'm able to feel it, so I have to stand with those people who says, yes, it is possible. It is not going to be easy. They have to practice a lot. They have to practice a lot. There are people who say they can feel the thickness of the hair through the telephone directly. Through the telephone directly, they can appreciate. So it's a unique thing we have on our fingertips. Only thing is we need to develop it. But yes, if a fresh graduate comes or the person who's just learning manual therapy, they says, no, it is all bullshit. You cannot feel it. Maybe they have not practiced it enough. So this is what I'll say. But yes, it is a very controversial, I must admit. You will see people standing on both sides.
Thank you very much, sir. You handled it very well.
That's a fact, actually.
Yeah, next question, I think Dr. Vaishali will answer.
Yes, sir. Sir, one more question which we found it very interesting and also would like to hear from you about it. In addition to these strong ligaments around the SI joint, does muscle play any role in its stability? The muscle around the
Yes,
SI joint.
yes. They
They
play
play.
a very, very important role. Very interesting question. Very important role. And sometimes student says, which muscle? To them, I say any muscle which is getting originated or getting inserted in the pelvic area, in the ilium, over the sacrum, any muscle, let it be piriformis, let it be quadratus lumborum, gluteus medius, maximus, and even the hamstring part, they all, and your spinal muscles, they all play very, very important muscles, or very, very important role, because it is not only the ligament, it is the muscle also which hold it. Okay, so if there is an imbalance between the muscles, yes, it will cause repeated positional fault, repeated pain, repeated uh, 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 joint strain. I take it as an example of, the tent, the tambu, and there is a pole in the center, and then there are ropes all around. If one rope goes slack or over tight, the pole, center pole, will bend on that side. Okay, and over the time with the micro trauma, it will get tear. So it has to be balanced all around.
Thank you very much, sir. Over to you, David, sir.
Yeah, we have actually segregated few questions and we are going to ask you alternatively, sir.
Please
So,
keep doing it.
sir, you at the end of your webinar, you said you are going to skip the part of self mobilization of SI joint and you are going to put it on the YouTube for the patients to view it and mobilize their SI joint. I just want to ask you, how effective is self mobilization of SI joint?
So actually, this question I should not be answering. My students, my staff, actually, they should be answering, because during the coronavirus lockdown, rather you should be answering. Okay, because during coronavirus lockdown situation, majority of the physio have done the tele rehabilitation, and they have taught all the self treatment, self mobilization, not only for the sacroiliac joint but for many other joints, and their patient has responded very well. So in short, yes, they are very, very effective.
Thank you, sir. I hope the physiotherapists and the students have got their answers. Yeah, next question, please.
Yes, sir. So my next question, which we have thought of, is about the role of electrotherapy. Whether, as we know, electrotherapy acts as an adjunct to many of the treatments which we go through. What about to the SI joint, the role of electrotherapy?
Yes, even I do believe strongly in electrotherapy. Okay, I'm not against it. And for sacroiliac joint, I prefer to do long wave diathermy. I'm not talking about short wave, I'm saying long wave diathermy, or the ultrasonic in that area. So what I prefer to do first is the hot pack, then the long wave or the ultrasonic to take care of the inflammation, and then do the mobilization, and then do the strengthening exercise. And maybe you should do the taping also to hold it there. So yes, electrotherapy do play a very important role, and one must try that. But make sure you are not doing electrotherapy to increase the blood circulation of that area, because inside the joint there is no blood supply. Cartilage get nutrition because of the movement of the synovial fold. Okay, so because of the movement, the cartilage will get nutrition, not because of increasing blood circulation. They should know why they are using the electrotherapy, and I'm in support of that.
Yeah. Sir, the next question is by, I think, one of the student, I think. See, you showed us a lot of gliding and a lot of techniques. How do you know you're gliding in right direction with correct force?
Okay. When it is right, the patient will have no pain. So I always ask patient, if you're feeling, if you know, the pain is your friend, pain is not your enemy. It tells you there is something wrong with the body. And if it is painful, it is not going to be the correct one. Body is not accepting it. And if it is pain free, why I should not believe it? Okay. So, but then how much pain relief? If patient says I'm, 5% better, 10% better, then he's only trying to please you actually, because you're working hard. So he's only trying to please you. It's going to be placebo. Okay. But if the patient says above 30, above 40 or 50% better, that means that's the glide which is working. And if he says, and about 30, 40%, I'll try to make it 80%. Okay. By changing my angle, level, direction, pressure, a little bit there or there. The fine tuning. Students do practice the short wave diathermy and they do the fine tuning. And they go a little more, it goes there. They go a little more on, it goes there. So they have to do the fine tuning. Or in our timings, we had the radios, and you do the fine tuning of the AM radio or FM radio, and then you get the best sound of it, best music. Best music is above 30% or 40% pain relief. Then you know you are on the right angle, right direction, right force.
Correct, sir. I hope that student got their answer. Next question, Dr. Vaishali.
So, sir, yes, sir. So, as you said, if the patient feels 10 to 20% better, then that means you're using a right glide. That's what you're coming to
No,
say.
that's a placebo. 10 to 20% is the placebo. It has to be about 30%.
Yes, sir. Fine, sir.
So,
David?
if there is a muscle weakness around SI joint resulting in instability, will manual therapy help patient? I repeat, this is from a doctor. If there is a muscle weakness around SI joint resulting in instability, will manual therapy help that patient? I think it's very apt question.
Answer is one word answer, no, manual therapy will not work. Now here, but I would like to explain because there are students, okay, they should know why it will not work. So suppose if you are in the deep water, okay, and you're dying for air, okay, you want to take a deep breath, and I serve you with the pizza, will that help you? No.
No.
You want to have oxygen, okay? And suppose you're feeling very hungry, very, very hungry, and I give you absolutely fresh oxygen. Will that help you? No. So when you are thirsty, you need water. When you're hungry, you need food. When you're feeling congested, you need more oxygen. So if the muscle which is at fault, you have to work for the muscle, not for the joint. Okay, so you have to find the cause behind it. If it is the muscle, you have to work on the muscle. Manual therapy will not work properly.
If it's a muscle, then I am there to help them.
Yes, I told that. Just
Yes.
before finishing, I said that contact Dr. David. He is the best person for the muscles and for the myofascial pains.
Thank you, sir. Next question, please.
Nicely explained, sir. Your example was really very good, actually. So the next one, I feel I personally also is very eager to know about this. Do you follow the evidence-based practice or the practice-based evidence?
Recently I posted a video because of that. Probably this question has come up. Okay. Yes, the question is whether I follow evidence-based practice or practice-based evidence. My answer is the one that works. So I do follow evidence-based practice, and yes, if there is no evidence but I'm getting the result, then at that time I follow practice-based evidence. Majority of my practice is evidence-based practice. But then there are certain techniques on which nobody has done any research till now. Okay, there is no evidence, there is no data on that, but I use those techniques also because I know they are working. Okay, but then there are evidences which says it is all placebo, so we don't do that. So I'm not in support or against evidence-based practice or practice-based evidence. I want to tell people you have to check it. Okay, you have to check the technique. Practice evidence-based practice or practice-based evidence, the one that works. Don't follow any of them blindly. Okay, if there is evidence-based practice, you should try yourself and check, is it a right one? And if there is a practice-based evidence, try to do research on that and build up the evidence for that. Okay, so both are good, and one has to follow both depending what is the situation.
Like how you said in today's session about the SI joint movements, you feel and then you get to know it. People have different opinions on that.
Yes, and you know, the best advertisement I like is the ghadi detergent. That says, पहले इस्तेमाल करो फिर विश्वास करो. Chapter closed. No discussion further. पहले इस्तेमाल करो फिर विश्वास करो.
Your examples are very good, sir.
That's why he's well known for these illustrations. Yeah. Lively, apt, on the time, punchlines and illustrations. So the last question, sir, we have been sitting for the last 1 hour, 51 minutes. And there are almost 1,000 people.
House is full.
House is full everywhere, even on YouTube. So this is the last question for the day. Before we wind up, so what to do if nothing works for SI joint pain?
What to do if nothing works for SI joint pain? Okay, for that, on funny side, I'll give you the right answer also. But let me tell you the funny side first. Bend your neck a little bit and turn towards your left side and look towards your heart. Okay, and ask it, क्या मैं खुदा हूँ? And if the heart says, अपनी औकात में रह, stay in your skin, okay, then answer is no. Okay, you know, you cannot treat everyone. You cannot treat everyone. First thing, you change the angle, direction, pressure, force, side, everything you're trying. It is not working properly. Either your assessment is wrong or your diagnosis is wrong, or maybe the patient has come up with so much of advanced condition that it is beyond the scope of physiotherapy or manual therapy. Go for detailed investigations. Go for MRI. Take the help of second opinion of other specialty. Okay, you are not Google. You are not God. You are not Lord Shiva who knows everything. Okay, so believe in teamwork. Talk to the other medical fraternity. Go for detailed investigation. Reassess your patient, or maybe take the help of your senior or other colleagues in the same department to start the assessment from the scratch again without telling your finding. Maybe you missed out something. Patient will not respond only in two conditions. Either your assessment is wrong or your treatment is wrong. In both conditions, clinicians, I believe, is wrong. You cannot put patient that it is psychological or the problem is in the head. You have to find out, even if it is in the head, it is your responsibility to diagnose that, okay, there is no pathological problem, it is psychological one, and refer patient to a clinical psychologist. But problem is there. Psychological pains are not false pain. They are also there. So again, it is the responsibility of the clinicians only. So if it doesn't work, take the help of other people.
Thank you so much, sir. You wonderfully answered that question. We cannot do everything and we cannot treat every kind of pain on the earth. There are certain limitations for every type of patients and every type of physiotherapist. So we have a feedback poll going on. I would request all the participants who are there in Zoom to kindly submit this poll and attend this poll, because that will help us in creating good webinars in the future, not only for IAP Karnataka, but also for Deepak sir and KP Institute of Manual Therapy, so that we can refine ourselves and correct ourselves and come out with better and good quality webinars in the future. So I hope.
And before they go, I must say thanks to Dr. Ruchi Gupta. She's behind the scene and she has been answering to all the participants, all their questions. And she's my head of the department in Capri. And thank you for switching on your camera, Dr. Ruchi. Here, the beautiful lady with the great brain comes. Okay, so she's Dr.
Thank you
Ruchi
so
Gupta.
much, sir.
He has been answering all your questions in the Q&A section and in the chat. And thank you very much for coming and helping us, Dr.
Yeah. So I have something to say. Thank you so much, sir, for such a lovely and informative presentation by you. I have been trying my level best, following your route only, the things you have taught us and the way we practice all together. So it was really being a very good opportunity for me and great pleasure to be working with you for this webinar in the Q&A section. I'm really grateful and thankful to be a part of it.
Thank you.
Thank you, Dr.
I
Ruchi
must.
Gupta. So before we
It was
do,
really enjoyable to be a moderator for you for your session. It was really a
Thank you,
proud
Dr.
moment.
Vishali. I enjoyed it. Went so smoothly, I believe. And thank you, Dr. David. He's a
thank you.
lovely teacher. I know him since long, lovely teacher. And last week we hosted his webinar, which is available on YouTube on dry needling. I'm sure you people can go there and see that webinar, which has already got more than 7,000 views. So that shows that he's a famous teacher in Karnataka.
Yes,
And that
sir.
was a lovely webinar. Thank you, IAP Karnataka branch. Thank you, Ifti sir and Dr. Sohail and Dr. Reddy and all the office bearer of Karnataka branch of IAP and Central IAP for giving this opportunity to interact with the fellow physios and sharing my insight about the sacroiliac joint because of the limited. Oh, Dr. Reddy is there online.
Hi, sir.
Okay.
Yes.
Okay. Thank you.
I'm following you. I'm listening to you, sir, from 9 o'clock.
Thank you. Thank you so much for
It
sparing
was
your
really
time.
wonderful talk, sir. And I usually don't listen after 8 o'clock. And first time till 11 o'clock, I'm listening. And it was
Honored, sir.
fantastic, sir. And pleasure to have you at this platform. And hats off to you, sir. And thanks to
I'm
David,
sure
sir, and
under your
Vaishal.
dynamic
No,
leadership,
sir.
our
It
IAP will
was
grow further.
fantastic, sir. So thank you very much, sir.
David sir is being very doing a lot of hard work, sir, on webinars, and
Yes,
all
yes,
his
yes,
skills
yes.
are shown clearly.
No,
First
it's
time,
all.
sir, I'm seeing more than 1,000 people at night, 11 o'clock, sir.
Thank you, sir. Thank you.
I've never seen, seriously. It's fantastic, sir. Thank you. Thank you so much, sir.
That's the charisma of Dr. Deepak Kumar, sir. And let me thank the entire team of IAP Karnataka branch, including our central IAP Vice President, Dr. Suresh Babu Reddy, who has joined in here, as the entire team which is working behind the scenes totally. It's not me or not Reddy sir or Vaishali madam. No, it's all the entire team. We coordinate each with each other over calls or over the WhatsApp groups, and then we decide and we talk to the speaker and then get everything going on. So we have been doing it from the right day one, and thank you very much, sir. And I want to thank personally Dr. Ruchi Gupta, who was the other panelist there, and she has answered 99 questions. I mean,
Wow.
and it's not orally, she was typing and answering, and I was following it, and she has been very good in answering all the questions.
He
And
has hit the century, huh?
yeah,
Maybe he has answered for the
one,
100.
one run lesser than century,
Okay, missed out.
It
like
was it was
Sachin Tendulkar.
99 not out.
it was really a
99.
great experience answering and following sir's videos, practicals, and everything. Meanwhile, I was switching the screen both ways, so it was really great working.
Thank you so much, sir. It was a wonderful presentation as usual. Right from theoretical part, from assessment, visual assessment, your palpation skills, your special tests, and the practicals to treat the patient. It was all in one complete package of SA joint dysfunction and management. Thank you so much for this
And this
wonderful
video is
webinar.
live on YouTube.
Yes.
So if any of their friend wants to watch this video, they can always go back and watch it and revise it again and again. And I also must say thanks to Dr. Tanmay Kumar,
Yeah, who
the
is the
technical support behind this webinar. He's the one who is helping us technically handling all the things. And thanks to Dr. Adya for getting all the insight and the data and the literature review for helping me preparing my presentation. And thanks to Akshit, the macho man of our family. Okay, he was the model, and he came all the way, and he helped me. He accepted to expose his body in front of my physios, and he accepted to become a model. Thanks to Akshit also. Thank you very much.
One
Thank
more
you very
thing, sir,
much.
I want to add in this. We thank Dr. Deepak for the analogies he always give, the words, the liners that keep us reminding all those things, all those techniques, difficult techniques in such an easy way. So I
Exactly.
think Dr. David, we need to add this to the list of our thanks to Dr.
New
Deepak.
addition is the Alu Bukhara technique. Alu Bukhara and the anaconda.
That's what
Anaconda
I was.
technique. And
I
that ghadi detergent ad was like apt in the situation. It was really complete fix in the situation.
I already mentioned about that. His one-liners and his illustrations are out of the box, and you cannot simulate them at all. It just flows. It just flows. Thank you so much, sir. And thank you, Dr. Reddy from
It's
Central.
Thank you
opened
all
our
the
eyes.
participants.
Thank
Thank you
you
all the
very much.
participants.
Those
Yeah,
are the
Thank you.
thanks to all the participants too.
Yeah. Thank you, sir.
Thank you.
Thank you very much, sir. Good night. Stay safe. Stay home. Have a wonderful